All right, I'm going to be covering the second half of the respiratory lecture. So we're going to start on page 6 of the chapter 23 handout, starting at the top, airflow, pressure gradients, and resistance. Gas flow is proportional to the pressure gradient over the resistance. This is the same as what we talked about with blood pressure and blood flow. Now, we're going to talk about the pressure gradient. The greater the pressure gradient, the greater, that's your first blank, the airflow into the alveoli. The pressure gradient can change by altering the volume in the thoracic cavity. That's what we do by breathing. Resistance. Resistance is inversely proportional to gas flow. Therefore, the greater the resistance, the less, that's the blank, the airflow. It's primarily due to the bronchioles, not bronchi, bronchioles, which have lots of smooth muscle in their walls, which is comparable to the arterioles in the circulatory system. The bronchioles are controlled using the nervous system. When they're under parasympathetic stimulation, that's rest and digest. When that's going on, there is decreased diameter of the bronchioles and increased resistance. So decreased diameter, increased resistance. Therefore, you have a decrease in airflow, which results in, we call that bronchoconstriction. Under sympathetic stimulation, so we're talking about fight or flight, you have increased diameter of the bronchioles and decreased resistance. That results in an increase in the airflow into the lungs, and we call that bronchodilation. We have medications that will do this. Albuterol inhalers do this synthetically. Now, asthma. Asthma is a result of severe constriction of the airway's smooth muscle. So we're talking about bronchoconstriction plus, so this is in addition to plugging of the airways with mucus. So not only are they constricted, they're also clogged. There are also physical and chemical factors that can alter resistance. If you take a whiff of ammonia, so smelling salts, things like that, that actually decreases the breathing rate because it increases resistance. Now, deep in the alveoli, these are going to be the little air sacs. First blank there is surface tension. Surface tension. That's the attractive force between the water molecules. All right, there's water molecules because all tissues, they're going to be moist. We don't really have dry tissues in our body. So the water molecules that are making the tissue wet have hydrogen bonding. That's the next blank, hydrogen bonding. Now, there's also another substance called surfactant. Surfactant is a lipoprotein, and it's a detergent. And it is produced by the type 2 alveolar cells, type 2. And what it does is it interferes with the hydrogen bonding so that the alveoli don't collapse on themselves. So detergent, think like Dial hand soap, what you use to get grease off your hands. It's going to interfere with water sticking to each other. So the water molecules can't stick to each other, therefore the alveoli stay open. And if you remember from when we talked about respiratory in lab, the type 2 alveolar cells, there are only about 5% of the cells in the lungs. Most of them are going to be type 1, which are the cells that are used for gas exchange. Now, ARDS, acute respiratory distress syndrome. This happens in infants. So it's important to note that the type 2 alveolar cells, which produce the surfactant, they become mature and active about 2 months prior to birth. So we're talking about 8 to 9 weeks. Without the surfactant, the alveoli collapse, and that means the baby has to reinflate all of the alveolar sacs with each breath in order to inhale. And that is absolutely exhausting. It takes a ton of energy to do. Now, there's a couple of things we can do if we know the baby's going to be premature. that we can do to treat this and help decrease the risk of ARDS. So what we can do is we can treat them with surfactant. We can actually make surfactant. It is very, very expensive to give and kind of painful to administer. But more often than not, if we know we're going to have to do, a C-section or something, you can actually pre-treat the mom with steroids. And that's going to speed up lung development prior to the premature birth if you know it's going to happen. So somebody goes into labor, maybe they say, well, let's see if we can keep her stable for, about 48 hours, and then we'll deliver the baby. What they do is they do two injections, and they're 24 hours apart in mom, and they're called antenatal glucocorticoids. And you'll know that, you'll see it on the floor as Celestone. It's a betamethasone. And that will actually speed up the lung development in the baby, so you decrease the risk. But a lot of times the NICUs will also still have surfactant on hand just in case. This can happen to adults too, particularly with pneumonia. I had a patient who was 14. Yeah, she was 14 in a pediatric ICU. She had double pneumonia, hit her chest x-ray, was like a complete whiteout. She wasn't able to move like hardly any air. And my professor, actually we dosed her with surfactant, and she got amazingly better within seconds. It's really an amazing thing to watch. Lung compliance. Ease with which the lungs and the chest wall expand. So how stretchy is the chest wall and the lungs. And that is very essential for inhalation, because when we inhale, we expand the torso cavity, thoracic cavity, and the lungs expand to fill the space. Inhalation, that's the blank. Now, in a condition like pulmonary fibrosis, normally, it takes energy to inhale. We talked about that last week. So it takes about maybe 5% of your body's basal metabolic rate, so the energy that you have to just normally inspire. So just to breathe in and out takes about 5% of your basic energy. Somebody with pulmonary fibrosis, where their lungs aren't very stretchy and elastic, it's going to take them 20 to 50% of their energy expenditure, their basal metabolic rate. So that's very exhausting. That doesn't leave a lot of extra energy to do things like move. Lung elasticity. This is the recoil ability, and that's what we need when we exhale, because we fill the lungs when we inhale. And then remember, the nervous system doesn't say exhale, it simply says stop inhaling. So you stop inhaling, lungs recoil, pressure increases in the lungs, forces air back out. All right, so in emphysema, this is an irreversible loss of pulmonary gas exchange because of widespread destruction of pulmonary elastic, that's the blank, connective tissue, which is also coupled with a breakdown of alveoli. So what ends up happening is, instead of having really small alveolar air sacs, they kind of merge together and they get bigger. The ones that you still have that aren't destroyed grow and get bigger because you're trying to get adequate gas exchange, but they're not really near as functional because ultimately you have a decrease in surface area. The primary cause is smoking, emphysema. So here, the patient actually has to use energy to exhale. Exhalation is not a passive process. So these patients develop what's called a barrel chest. Their chest wall expands because they can inhale. They don't have trouble inhaling. There's not an issue with their ability to expand the chest wall. However, they can't exhale because their lungs don't recoil, so air will tend to stay trapped in the lungs. Therefore, they actually have to use accessory muscles. Think about how tired you get when you cough, or not really sneeze, but when you cough a lot, they have to go forcibly exhale in order to get that air out because their lungs don't recoil. So that results in an increase in the muscular volume of those accessory breathing muscles. They're also known as pink puffers because they can inhale, so they have oxygen. So they're pink because they're having some gas exchange, but they have it costs them lots of work and energy to exhale, so they puff. You can usually hear them breathe. So they have a quiet inhale, and then they exhale loudly. That's what they tend to sound like. All right, turn the page. Page 7. We're talking about respiratory volumes and respiratory capacities. All right, this is on page 924, figure 23.4. That would be this chart. It's not very easy to see, but there's a copy of it in your handout. Now, we measure that with a spirometer. That's the blank, spirometer. Now, you have total dead space. That's the anatomical dead space. So the amount that's in the organs, you know, the organs that move air. So you're talking about the trachea, the bronchioles, the mouth, all that space. And then you have the alveolar dead space, which is the volume in the alveoli where we actually do exchange gas. So the air passageways plus the alveoli. Now, you do need to know the terms, what each of these terms mean. I'm not going to go over them right now, but you do need to know them, so please learn them on your own. You don't have to know a lot of the actual volumes with the exception of normally, and we're talking about kind of an average, males, females, whatever. Tidal volume, that is what's happening when we're talking about quiet breathing, so just breathing at rest. Breathing at rest, you're actually only exchanging about 500 milliliters, that's half a liter, of air with each breath. Compared to vital capacity, this is the total amount that you can move air, hold air, and exhale air in your lungs. So that's going to be around 4,800 milliliters. So on a normal basis, we're only using about 1/10 of our lung capacity in order to move air. So it leaves us lots of ability to increase for anything that's going to require increased oxygenation, whether that would be something like exercise or illness or stress or trauma. Now, we're going to talk about the gas exchange part of respiration. We've already talked about all the mechanics of breathing. Now we're going to talk about what actually happens in the alveoli as far as gas exchange. So, at rest, the body's cells are generally going to consume about 200 milliliters of oxygen per minute. And that means they're going to produce approximately 200 milliliters of carbon dioxide per minute. That happens as a result of aerobic cellular respiration. That's the blank. Now, we have our trusty equation, aerobic cellular respiration. So we're talking about a glucose molecule, C6H12O6 plus 6 O2s yields, that's the arrow, 6 carbon dioxides plus 6 waters plus 32 ATPs. So we're getting energy. So we use 6 oxygens, we get 6 carbon dioxides. So the amount of oxygen, the amount of carbon dioxide should always be equivalent. Now, at the lungs, the oxygen is going to enter the blood at the same rate that carbon dioxide, so that's an error in the handout, so you need to mark that out. Carbon dioxide leaves the blood at the body cells. At the body cells, CO2 enters the systemic capillaries at the same rate that O2 enters the body cells. So they're exchanging at the same rate according to the chemical equation. Oxygen goes in, CO2 comes out. CO2 goes in, oxygen comes out. Gas exchange in the lungs and the body, it depends on diffusion. That's the blank, diffusion. Remember, diffusion is a passive process. We're talking about substances that are going to move from high concentration to low concentration. Diffusion is a passive process. It does not take energy. It does not use any ATP. Now, before we start talking about this, basic properties of gases, because oxygen and carbon dioxide are gases. Gases are individual molecules. They're moving very fast, and they're bombarding the walls of their container. And how often they're actually hitting the walls and coming into contact with the container creates the pressure. So we measure pressure. Now, you can increase pressure a couple of ways. By increasing the temperature. When you increase the temperature, you are increasing the kinetic energy, which would be the speed of the molecules. So that means they're hitting the walls of the container more often, so you see increased pressure. You can also increase the concentration. You put more molecules in, ultimately, you're going to get more collisions with the container. Now, there's a principle called Dalton's law of partial pressures, which means the pressure exerted by each gas in a mixture is independent is the blank, of the pressure exerted by other gases. So it doesn't matter what the pressure of nitrogen is. It doesn't affect the pressure of the oxygen in a mixture. And remember, we are inhaling room air. Room air is a mixture of gases in the atmosphere. Now, partial pressure, that's the next blank, is the pressure that's exerted by each type of gas within the mixture. And partial pressure is what we use to determine the concentration of the gas. We measure concentration of gases according to the partial pressure. And so we abbreviate that with a P and then the gas. So you would see something that looks like PO2 or PCO2. Now, the total pressure of the mixture of gas, like room air, is going to be the sum, you add them all up, of all the partial pressures of the different types of gases. Turn the page. We're going to talk about this. Now, atmospheric pressure. If you remember, for my numbers people, atmospheric pressure is around 760 millimeters of mercury. That's how we measure pressure, millimeters of mercury. Now, if you do a little math, if you get out your calculator and you do 760 and multiply that by 78.6%, so 78.6 and then divide by 100, the partial pressure of nitrogen is going to be 597 millimeters of mercury. Oxygen makes up 20.9%. Do the math there. You should get something around 159 millimeters of mercury. Carbon dioxide makes up 0.04% of the atmospheric air. So that is 0.3 millimeters of mercury. Water vapor makes up 0.46%. Do the math. Partial pressure of water in the atmosphere, 3.5 millimeters. You add it up, and I think you get 758.8, which we're going to round up to 760, because there's some other random inert things. Now, the partial pressure gradient. So we're going to talk about gases. The movement of the gas depends on the concentration of that gas. So each gas moves down its own concentration gradient. So if you have, here I've drawn a box. If you look on your completed handout, there's a box. Dots represent oxygen. So I've got 5 of them. So we got 5 millimeters of mercury for oxygen. The dashes, that's CO2. There should be 3 of them. There's not. There's 3 of them now. 3 of them. And the X's are going to be nitrogen. So P of nitrogen is 2 millimeters of mercury. So 5 plus 3 plus 2 results in a total pressure of 10 millimeters of mercury. Now, there's another box. This is another container. Or whatever, the other side of the membrane. Dots are still oxygen. There's only 3 of them. So we have 3 dots of oxygen. 3 millimeters of mercury. The CO2 represented by the dashes, there are 6 of them. So that's 6 millimeters of mercury, for example. And the X's There's only one of them. That's the nitrogen. 3 plus 6 plus 1 is still 10. So the total pressure has not changed. But across this membrane here, which I've drawn representing 2 boxes, we're gonna see which way, left or right, these gases are gonna go. Now, so oxygen, there's 5 on the left, 3 on the right. So we're gonna move down the concentration gradient, high to low. So oxygen is gonna go to the right. Carbon dioxide goes down its concentration gradient. 3 on the left, 6 on the right. 6 is bigger than 3, high to low. Carbon dioxide is going to move to the left. Nitrogen, because there's nitrogen in room air even if the body doesn't use it. 2 on the left, 1 on the right. Goes from high to low, so nitrogen will also move right. So remember, it depends on the concentration of each specific gas, and the total pressure here is not changing on either side of the membrane. Now, that was a general example. Let's talk about it, what happens in the alveoli. So we've got a pulmonary capillary, and you can find this. This is simply, I've drawn a representation of the figures on page 926, figures 23.5. So first, in the alveolus, look here. First, you've got a pulmonary capillary. There it is. Now, inside this pulmonary capillary, the PO2 is around 40. If you can see that. Yeah, 40. And the PCO2 is going to be about 45 in the capillary. If you look in this part up here, this is actually in the alveolus, so what's in the lungs, so where we're inhaling room air. The PO2 in the lungs looks like 104 millimeters of mercury, and the PCO2 is 40. So now, look at each gas, and it's going to move down its concentration gradient. So the oxygen concentration is higher in the alveolus than it is in the pulmonary capillary. 104 is greater than 40. So oxygen moves from the alveolus into the capillary. Blood moves from the lungs, oxygen moves from the lungs into the blood. Now, CO2 is 40 in the lungs, in the alveolus, and 45 in the capillary. It's also going to move down its concentration gradient. 45 is greater than 40, so it's going to move down from the pulmonary capillary into the lungs, which will then be exhaled out. Now, once you get in the systemic capillaries, which is this second, here we go. Yeah. Now, in the systemic capillaries, in the capillary, the partial pressure of oxygen is going to be around 95 millimeters of mercury. The pressure of CO2 is going to be around 40 millimeters of mercury in the capillary. Now, blood is not going, or oxygen and gases are not going to move directly into the cells. They're going to move into the ECF. So that's what we're actually measuring, concentration of the tissue bed, gases in the tissue bed. So in the tissue bed, the extracellular fluid, the pressure of the oxygen is going to be around 40. So oxygen moves down its concentration gradient. 95 is greater than 40, so it's going to move out of the capillaries into the tissue bed, into the fluid. CO2 concentration in the tissue bed is 45. In the capillary, it's going to be around 40. 45 is still greater than 40, so it's going to move from the tissues out into the blood. Gas moves down its concentration gradient. So you have to look at which one is greater where. Think about what's happening. Now, impairment of gas exchange in the lungs can happen when you have increased thickness of the respiratory membrane. So the gas exchange, the walls in the alveoli get a little bit thicker. This can happen when you have like swelling, so maybe there's a little bit of like water pockets. That happens with a condition like pneumonia or something like a pulmonary effusion. there's something that is creating extra distance that the gas has to flow across. So remember, the thinner the barrier, the easier the gas can move because it has a smaller distance to cross. Now, you can also have decreased surface area. Remember, the lungs, the alveoli contain a whole lot of surface area. They're very small, so they can actually expand to take up a lot of space. In a condition like emphysema, what happens is a lot of the alveoli end up kind of withering away. So the ones that are left, they become larger. So therefore you have fewer of the really smaller ones, so you have bigger ones. So you have decreased surface area. Think about it like you have a lot more capillaries than you have arterioles. So think about it sort of like that. Turn the page. Let's talk about the gas transport concept of respiration. Now, we're going to talk about Henry's law. You don't need to know the name of that. It's not on the test. It's going to explain the solubility of gases that are in a liquid because, you know, we're not actually moving little gas bubbles in our blood. Now, Henry's law says the solubility of gases depends on the temperature, the partial pressure of the gas, and what's called a solubility constant. We're not going to be dealing with any real numbers here. But just know that in the blood, carbon dioxide is significantly more soluble, so it dissolves in the blood a lot more easily than oxygen. Oxygen dissolves a lot more easily in the blood than nitrogen. All right, transport of oxygen. Let's go back and talk about hemoglobin. We've already talked about this once. Each hemoglobin can carry how many oxygen molecules? 4. Each hemoglobin contains 4 globin chains. Each globin chain contains 1 heme molecule that contains the iron, and that's what holds the oxygen. So 4 oxygens per hemoglobin. All right, names again. Let's remember this. Oxyhemoglobin, that's hemoglobin that's carrying oxygen on it. If it is fully saturated, that means it has carrying all of its O2s, the maximum number. So how many can it hold? 4. Hemoglobin plus 4 oxygens is fully saturated. We call it partially saturated when hemoglobin has oxygen on it, but not 4. So if it has 1, 2, or 3 oxygen molecules, it is partially saturated. Deoxyhemoglobin, on the other hand, is not carrying any oxygen. It's hemoglobin with no oxygen. Now, we talked about this before. This is still a review. Conformational changes occur when one oxygen is bound or lost from hemoglobin, and that's going to enhance or gain the loss of the other 3. So what happens is hemoglobin is a protein, ultimately, and proteins like to stay how they are. They don't want to change. So it takes some energy or effort or whatever to get something to happen. Once it happens, it says, okay, I'm cool with it. We can load more or we can unload them all. So it's called the cooperative binding effect. So if you have a fully saturated hemoglobin, the one that is hardest to remove is always the first one. Because remember, it likes to stay where it is. It's got all 4 oxygens, so it wants to hang on to them. Once you pull the first one off, fully saturated hemoglobin, that's bright red. Once you pull the first one off, the rest come off easier because it says, okay, well, I'm not fully saturated anymore, so you can just have them. Now, on the other hand, when you have deoxyhemoglobin, it has 0 oxygens on it. So the hardest one to attach is going to be the first one because it wants to stay how it is. Once you load the first one, the other 3 go on easier. Deoxyhemoglobin is dark red. Conformational change. Now, if you go back to the top of the page, I told you that oxygen is significantly less soluble than carbon dioxide in the blood. So how much is actually dissolved? Only about 2% of the oxygen that you carry in your body at any one time is actually dissolved in the plasma. So most of it is transported on the hemoglobin. It's bound. Oxygen is not very soluble. So what happens is the hemoglobin, it gets loaded up with oxygen while it's in the lung, while the blood's in the lungs, pulmonary capillaries, oxygen moving from the lungs into the blood down its pressure gradient. So a lot of the hemoglobin becomes fully saturated. It wants to stay that way. It's happy. In the systemic tissues, you have the dissolved oxygen that is in the blood, because some of it is still there, and it's going to move from the blood into the cells. But most of the oxygen is still going to stay bonded to hemoglobin, so you've got an oxygen reserve. Now, carbon dioxide, this is important. We talked about this last week on the test. Now, I am going to be looking at figure 23.27, which is on page 931. All right, this is important. A small fraction of carbon dioxide, so we're going to be talking about all the carbon dioxide that is in your body. About 10% of it is actually physically dissolved in plasma. That's the blank. Because carbon dioxide is more soluble than oxygen, if you look up at the top of the page. So 10% of carbon dioxide is dissolved in the blood, plasma, versus 2% of the oxygen. Now, about 25%, that's the next blank, of the carbon dioxide is going to react directly with the hemoglobin. And it's going to form carbaminohemoglobin. Carbaminohemoglobin. Carbon dioxide bound to hemoglobin. Now, in order for this to happen, carbon dioxide and oxygen cannot be bound to the same hemoglobin molecule. Never, ever, ever. So, if a hemoglobin molecule is partially saturated or fully saturated, no way it's binding to carbon dioxide. However, if you have a deoxyhemoglobin molecule, which you're going to have more of those in the tissues, CO2 can bind to that. Once CO2 binds to that, oxygen does not bind. Okay? So carbon dioxide plus hemoglobin turns into carbaminohemoglobin. Now, that's another way. However, the largest fraction, so that would be the remaining 65%, is going to react with water to form the bicarbonate ion. All right, this is on the test. We've already written it down. You need to learn it, remember it, don't forget it. All right, the equation is carbon dioxide plus water reacts to form carbonic acid, H2CO3. H2CO3 is not very stable, so it will break down to form the bicarbonate ion, HCO3 minus, plus a free hydrogen ion, H plus. The bicarbonate ion, HCO3, is very, very, very soluble. So it gets in the red blood cells. So when you're in the red blood cells, this enzyme called carbonic anhydrase causes carbon dioxide to form carbonic acid, which will then break down into HCO3. So it's going to be dissolved in the plasma. So most of the CO2 is going to be dissolved in the blood plasma as a result of being carried as bicarbonate. So bicarbonate technically represents CO2. The red blood cells, they're the ones that hold the carbonic anhydrase enzyme. Yes, you need to know the name carbonic anhydrase enzyme. Now, the hydrogen, free hydrogen ion, remember free hydrogen makes things acidic, is going to react with the hemoglobin, and that's going to trigger what we call the Bohr effect. We're going to talk about that more in a minute. So when you have an acidic environment, it tells hemoglobin to release oxygen. It says, whoa, we got acid here. That means we have more CO2. We need to dump some oxygen. And then the bicarbonate ions, they can freely go wherever because they're very soluble. They can cross the cell membrane and they'll go through the plasma until it gets to the lungs. Now, the increase in CO2 concentration is what drives all of these reversible reactions. So this reaction goes both ways. One way it's going to go when you have high CO2, it's going to, carbonic anhydrase is going to form carbonic acid, which is then going to form bicarbonate and a hydrogen ion. When you have low CO2 concentration, the bicarbonate and hydrogen ion are going to recombine to form carbonic acid, which will then dissociate into CO2 and water. It can get kind of confusing. But, so as blood flows through the lung capillaries, in the lungs, so now we're back in the lungs, the CO2 dissolved in the blood is going to be higher than the concentration of CO2 in the alveolar air. So that means the reaction moves to the left. So we want to form carbon dioxide so that we can breathe it out. So in the lungs, the reaction moves to the left. In the tissues, the reaction moves to the right because we're picking up CO2. Concentration of CO2 is going to be increasing, so we're going to need to transport it. Turn the page. Now, hemoglobin is a transport molecule. We're still on page 931. Here's a picture of the curve. It's S-shaped. So generally, what happens here is the oxygen saturation. This is how much hemoglobin is bound to oxygen. So in the lungs, you've got around 100%. So that means you've got 20 mils of oxygen per 100 milliliters of blood, according to this. However, and then when we get to the tissues, the partial pressure of oxygen, so the partial pressure of oxygen here in the lungs, 100% up here, and relatively 100% in here, partial pressure. Maybe not 100, this is not 100%, this is 100 millimeters of mercury. Sorry. Yeah, because it's 104. All right. Now, when we get to the tissues, the partial pressure of oxygen is 40. Now, look, we've only actually dropped off about 25% here. We go from 20 to 15 of the oxygen that's carried in our blood. Now, once the oxygen in the tissues gets really low, we start dropping off oxygen really quick. So we've got a reserve, but we go through it really, really quickly once the partial pressure of oxygen starts really dropping. Okay? Now, the oxygen that's bound to the hemoglobin does not contribute, because it's bound, to the PO2 of the oxygen that's in the blood. Only the free gas molecules are what contribute to the PO2 of the blood. So the diffusion of the oxygen into the tissues is relative only to what's actually dissolved. So what we're carrying on hemoglobin doesn't really count. It's just the reserve. Because hemoglobin allows you to carry humongous amounts of oxygen in the blood as a reserve in case you need it. So you're only going to unload, as I told you up here in the graph, about 20 to 25% of the oxygen in the capillaries. So you have a large reserve for when you need it. All right, let's talk about things that are going to cause hemoglobin to release more or less. All right. Influences in temperature, pH, partial pressure of carbon dioxide, and BPG. We'll talk about that in a little bit. An increase in any of these is going to cause hemoglobin to unload oxygen. So an increase in any of these things is going to trigger oxygen release. Now, first things first, temperature. So when we increase the temperature, what condition would temperature be increased? It happens when you're ill or generally when you're exercising. Why do we need more oxygen when our temperature is increased? Because the cells are going to need oxygen for an increased basal metabolic rate. Increase in temperature represents an increased basal metabolic rate So you have increased ATP needs. You can't make ATP efficiently without oxygen. Now, all right, acidity, that would be pH. This is what was referenced on the previous page, is the Bohr effect. The Bohr effect is not going to be, the name is not going to be on the test. The principle of it, absolutely. All right, so remember, when we have increased CO2, our reaction moves to the right. That means we have bicarbonate and a free hydrogen ion. Free hydrogen ion makes things acidic. So when we have things that are more acidic, the pH is lower. So lower pH means more acidic. So hydrogen concentration is going to be higher in the tissue capillaries than in arterial blood. So if the hydrogen concentration is higher, that means there is a lower pH in the capillaries than in the arterial blood. So you have a lower pH, means you have a higher concentration of hydrogen. That tells hemoglobin, hey, I need more oxygen, because it's a representation of an increased amount of CO2. On the other side, hydrogen concentration is going to be lower in the lung capillaries than it is in systemic venous blood. Lower H+ concentration means pH is higher. So that means hemoglobin is going to load oxygen and it's going to hold on to it pretty tightly. So you have a higher affinity for oxygen with a higher pH, so less acidity. Now, BPG, that is something that's called 2,3-biphosphoglycerate. This is formed by red blood cells during their anaerobic respiration. Remember, red blood cells do not have mitochondria. They do not use aerobic cellular respiration. It is anaerobically. So when they are doing anaerobic cell respiration, they produce BPG. BPG binds reversibly with hemoglobin, and when it binds, it causes it to change shape and release O2. Why is this beneficial? When the red blood cells are busy, meaning blood is moving, they're doing stuff, they're having to change shape and whatever, that happens because you are busy, you are moving, you are ill, something is causing an increase in blood flow. You are busy, you need more oxygen. So the red blood cells are working harder, so you get more BPG. It says, hey, we probably need some more oxygen in the blood, so let's unload it. Now, if you look at the graph here, so on page 931, there's the standard curve there. Now, if you look here, when you are exercising, so here's at rest. When you exercise, the curve looks more like this. So when you're at a partial pressure of 40 here in the tissues, you're only at 20% saturation. So you are using a whole lot more oxygen. So this curve has moved from the left to the right. That's called a right shift. This can happen as a result of increased temperature. It can be as a result of increased acidity, the Bohr effect, anything that's going to say, hey, we need to release more oxygen. So that means at the same partial pressure, you have a lower amount of oxygen that's still stuck to hemoglobin. If you have less that's stuck to hemoglobin, that means more of it is out in the tissues. So you have less reserve. So that can happen when you have an increased temperature, when you have increased acidity, or when you have increased BPG. All of those cause the curve to move to the right. That's called a right shift for my visual people. Now, PCO2. We've also talked about this. So that means increases in concentration of CO2. When would you have an increase in CO2? When you're exercising, when you're ill. Why is this beneficial? Body cells need more oxygen. That's what it indicates. You are making more CO2. That means you need more oxygen. Turn the page. Impairment of oxygen transportation. This is the last page. Bear with me. All right, the first one, low oxygen delivery to tissues. That is called hypoxia. Hypooxygen. Hypo means low. Oxia refers to oxygen. Condition of low oxygen. All right. That can result in a condition that makes you cyanotic. Cyan means blue. So cyanotic. That's where you turn blue as a result of hypoxic tissues. So if you look at somebody, that you look for the blue lips there. Sometimes, when it gets cold and you have decreased circulation, the fingertips and nail beds turn blue or purple. There's a condition of hypoxia that's called anemic hypoxia. That's where you don't have enough red blood cells or hemoglobin in order to effectively transport enough oxygen. So the hypoxia is due to anemia. There's also a condition called stagnant hypoxia. Stagnant, so we're talking about no blood flow. So the circulation is going to be impaired or blocked to certain tissues. That can be a result of a thrombus, so a clot, an embolus, a clot in the lungs. If it's a clot in the brain, you're talking about a stroke. So you're not getting blood flow, therefore you can't get new oxygen and gas exchange there. Or congestive heart failure, so you're just basically not getting a whole lot of blood movement anywhere as a result of a defect or inefficiency of your ventricles, particularly the left ventricle. All right, there's also a condition called hypoxemic hypoxia, which sounds redundant. It sort of is, but not really. All right, so that's an interference with gas exchange in the lungs. So the lungs aren't able to actually move oxygen. Example, carbon monoxide poisoning, CO. It's just different than CO2, carbon monoxide. Now, this is important because hemoglobin, which is what we use to carry oxygen, it likes oxygen. However, it likes carbon monoxide 200 times better. So if it has its preference of carbon monoxide to oxygen, it's going to pick 200 carbon monoxides before it picks one oxygen. So that means the hemoglobin is loaded up, but it's not loaded up with oxygen. So you can't actually get oxygen moving. But remember that bound hemoglobin is bright red. So these people look bright red. They look pink. So carbon monoxide with hemoglobin, their skin looks bright pink. So it looks like they're oxygenating. But because their hemoglobin is saturated, but it's not saturated with oxygen, it's saturated with the wrong thing. So that's a problem. So it doesn't take very much carbon monoxide in order to cause carbon monoxide poisoning. That's why we have detectors in the homes. That's why they talk about caution with exhaust in the vehicles. So don't turn on your vehicle without having your garage door open, things like that. Now, transport of hydrogen between the lungs and the tissues. This is the same chemical reaction. Know it, love it. Carbon dioxide plus water. Uses the enzyme reversibly, carbonic anhydrase, to form carbonic acid, H2CO3, which then breaks down into bicarbonate, HCO3 minus 1, and free hydrogen, H+. Now, most of the free hydrogen ions, they don't stay free in the blood. They're actually transported to plasma proteins or bound to hemoglobin. Mostly they're going to be bound to hemoglobin because that's where the carbonic anhydrase is. So it's just easier for them to just snatch on there. Now, deoxyhemoglobin, that's hemoglobin with 0 O2s on it, has a much greater affinity for hydrogen because it doesn't have any oxygen on it than does oxyhemoglobin. That would be hemoglobin with 4 oxygens. So as blood flows to the tissues and it unloads oxygen, the hemoglobin is able to pick up hydrogen ions. That's the point. So ultimately, the body's really smart, so you don't have very many free hydrogen ions floating in the blood. So the venous blood pH is going to be higher, but only by a little bit, little bit, than the arterial pH. Remember, we're talking about blood 7.35 to 7.45. That's probably a good indicator. Lower pH, more acidic, 7.35, probably going to be a result of venous blood. 7.45, less acidic, probably going to be a result of what's going to be in the arteries. Okay? Now, let's talk about what happens in the lungs. I've already mentioned this. Here we're going to talk about it. Write it down. In the lungs, you have more CO2. So what happens in the lungs? You've got the ability to exhale. So the reaction goes to the left. H plus bicarbonate going to recombine to form carbonic acid, which is going to dissociate into carbon dioxide and water. You can exhale the carbon dioxide. So the reaction goes to the left in the lungs. This is the same reaction as this up here. We just don't have the arrows going both ways. Now, breathing rate and hemostasis. We already talked about this a little bit last week. Carbon dioxide and free hydrogen on blood pH. Remember, pH, measure of free hydrogen ions in the blood. Now, hypoventilation, because we got our chemoreceptors, especially the ones in the brain, that are going to be testing CSF, measuring the acidity, which is going to be the result of, so more acidity means more carbon dioxide, ultimately. Now, hypoventilation, slow, shallow respirations. You are going to be building up the amount of CO2 that you have in your body. So when you have increased CO2, it's going to combine with water to form carbonic acid, which is then going to dissociate into bicarbonate and free hydrogen. So that means the reaction goes to the right. So when you have, this is an equilibrium reaction, so when you have more carbon dioxide, it's going to combine with that, form all of this. Okay? So when you're not breathing, increase in CO2 says, oh, we need to release oxygen, and we probably need to breathe. All right, now, respiratory acidosis. That's what it results in, because you need to breathe. So you have more free hydrogen. So you have decreased pH. When you are acidic, that is acidosis. The acidosis results because you are not breathing. So it has a respiratory origin, respiratory acidosis. Now, hyperventilation. Remember we did this exercise, so you should try it again. Deep ventilation, so we're blowing off a whole lot of CO2. So we have a decrease in CO2 concentration because we are exhaling it all. So when we have a decrease in CO2 here, our reaction is going to the right. No, to the left, sorry, going to the left. So we are breathing off lots of this, so we are getting rid of free hydrogen. So our reaction is going to the left. So we have less free hydrogen. What happens to our pH? pH goes up. We call that condition being more alkaline. So we call that alkalosis, more alkaline. Blood is more alkaline. That happens as a result of hyperventilation, so it has a respiratory origin. We call that respiratory alkalosis. That is the end of the respiratory handout.